So so our mission at ECHO is to democratize the implementation of best practices for healthcare and education to underserved people all over the world. What do we mean by democratized implementation? What we're saying is ECHO is not the most effective model in the world to disseminate knowledge. Actually, that's a better way to do it, Google or something. But our mission is to democratize the implementation of knowledge, to help people implement this best practice in their communities so that we can make a difference in the outcomes of patients. Our goal is to touch the lives of 1 billion people by 2025 by moving knowledge, not people. But going back to that patient, I developed ECHO in 2003 with 2 goals. We would safely and effectively treat hepatitis C everywhere in New Mexico and to monitor outcomes, and that we would bring access to care for complex diseases in rural locations and developing countries. The idea was, look, if we can give chemotherapy in a rural area and treat hepatitis C, then we can also treat diabetes and mental health disorders and so on and so forth. And your ECHO center, TexLa, you do ECHO for many things, not just for hepatitis C or not just for, and I think this is the main idea behind ECHO, is to use it for the biggest problems your community is facing. And I know of no other example that does a better job than Texas Tech at doing this work. So thank you for that. So when I developed the ECHO model, I said there were 4 key principles on which the model would be based. One is to use technology to leverage scarce resources. So today we are using Zoom, but Zoom wasn't available, right? So we bootstrapped a solution, but it was similar to Zoom. I'll show you what it looked like in a moment. And we said we would leverage the expertise of a gastroenterologist, a psychiatrist, and a pharmacist. The second key idea was to share best practices. So what I did is I drove around the state of New Mexico in 2003 and gave talks on the ECHO model and hepatitis C. And I asked these communities, I said, hey, I need one person in your community to step up and become an expert in treating hepatitis C, because too many people are dying in your community. And I gave them my protocol for treating hepatitis C. But guess what they told me was, look, this is too complicated. This is chemotherapy. We can't do this. This is dangerous treatment. We haven't done fellowship trainings. So I asked myself a question. I said, Sanjeev, how did you become an expert in treating hepatitis C? When I did my fellowship in Boston in Massachusetts in gastroenterology, I would see a patient and present to my professor. I would see another one, present to my professor. As I did this week after week, 2 years later, they started calling me a gastroenterologist. I said, aha, I'm going to use the same model to create new hepatitis C-ologists in New Mexico without them having to do fellowship training or residency training. They can stay in their local area, in a rural area. They can participate in my ECHO once a week, and they will become experts. We call this idea case-based learning, iterative guided practice. All teach, all learn. I think I see many residents in the room. And, how do you learn? You learn not only on your own cases. You engage in something which we call all teach, all learn every day on rounds in internal medicine. You learn on your patients when you present them to your attending, but you also learn on other people's cases as you're doing rounds. So we said, okay, this will be all teach, all learn. And the idea of ECHO is, if you want to teach your daughter to drive a car, you cannot just give her lectures on driving a car. What you want to do is sit next to her and give gentle feedback, making sure you don't mess up your relationship with her. And over time, take her from novice to expert. That's ECHO. And then we said we would evaluate outcomes. So what we started doing is we started training physicians, physician assistant, nurse practitioners. We trained them on our web-based software, and then we started conducting these ECHO sessions called knowledge networks in 2003. This is what it looked like. The first ECHO projects we started. This in the big box was the university, psychiatrist, pharmacist, and me. All 21 would join, and one by one, we would do this Wednesday at 3 p.m. And one by one, they would present patients of hepatitis C to each other and to us at the university, and without their names of the patient, and we would discuss those cases. And we would do this, and every week we would discuss 7, 8 patients, and 15 minutes I'd give them a lecture. To our amazement, in 1 year, they became as good as us. They didn't need fellowship training through a process called a learning loop. They learned from our advice, they learned from each other, but mostly they learned by doing. And this created a learning loop, and they rapidly accelerated their training from novice to expert. In 18 months, another very astonishing thing happened. And that was the wait in my clinic, which was 8 months, fell to 2 weeks. And everybody in New Mexico could get treatment for hepatitis C within 2 weeks if they wanted it. Even today, that's the case. You want hepatitis C treatment in New Mexico, you can get it right away by a local doctor participating in ECHO. And then we, of course, gave these people CME credits, just like your ECHO center is giving you CME credits. But we found that it was also doing more than knowledge. It was giving people professional interaction with their colleagues and producing joy of work by bringing a mix of work and learning and giving them access to multiple specialists. So as you have realized, all of you, this is different from traditional telemedicine. Traditional telemedicine is a very powerful technology. And I'm sure all of you who are internal medicine residents and attendings there saw during the COVID world how you were able to treat patients on telemedicine. It was a game changer. But this is different. This is a capacity building tool. The goal is to train other people to become as good as us. Why do we need what we call force multiplication? The vast majority of people with mental health disorders in the United States, for example, with addiction disorders, don't have access to a highly qualified expert. All over the world, there are not enough physicians, there are not enough experts. So in addition to regular telemedicine, which is a game changer, we need a capacity building tool. So we, here in ECHO, train teams in primary care settings who then help hundreds and thousands of patients. We call this idea force multiplication. So being a professor, I wanted to do research. So I said, I remembered that these doctors and nurse practitioners, half the nurse practitioners, didn't want to treat hepatitis C. So they needed self-efficacy. So I evaluated that. Scale is 1, I have no skill. 7, I'm an expert who can teach others. We asked them, what's your ability to identify suitable candidates for treatment? Went from 2.8 out of 7 to 5.6 in 12 months. What's your ability to treat hepatitis C and manage side effects? 2 to 5.2. One of the challenges we faced in New Mexico in rural areas, there were no psychiatrists. And interferon injections cause depression. They could make you suicidal. So we asked them, what's your ability to assess and manage psychiatric comorbidities? and treat these psychiatric conditions, 2.6 to 5.1. The other challenge we had was there were thousands of doctors and nurse practitioners in New Mexico, and I was only training 25 of them. How would that help all patients? They had to, first of all, become experts, but then they had to accept referrals from the other internists and family doctors in their area. So can you serve as a local consultant? Went from 2.4 to 5.6. Overall competence 2.8 to 5.5, and we published this in the leading liver disease journal in the world called Hepatology in 2010. We started doing other studies. Why would these primary care clinicians devote so much time to become experts? And you can see 97, 94, and 98% felt that achieving competence was beneficial for them. They weren't coming just for their patients. They were coming because it was a professional build, a development tool for them. Another surprise was it was producing joy of work. Project Echo has diminished my professional isolation 4.3 out of 5, enhanced my professional satisfaction 4.8 out of 5. Collaboration is a benefit to my clinic. I can assure you that your rural doctors in Texas love the idea of interacting with Texas Tech and learning from you and sharing their experience with you. What we call all teach, all learn means they have the ability to tell you about social constraints, economic constraints, culture, and how you can work together to improve care. All of this was good. But the real question that we had to answer was, could these rural doctors who were non-specialists give chemo in a rural area and get the same outcomes as us at the university? So we did this study with a federal grant from the US government. The study was called Outcomes of Treatment of Hepatitis C virus infection by Primary Care Providers. The objective was to train these clinicians in rural areas to deliver Hep C treatment to rural populations to show that they could do it as safely and effective. And one of the challenges we were facing was Hispanic patients had much lower access to treatment in New Mexico. So we wanted to show we could change that. So now I'll show you what we did. We took these 21 clinics, 5 were prisons in rural areas, 16 were rural clinics. Control was the University of New Mexico Liver Clinic. And the principal endpoint was sustained viral response, no detectable virus 6 months after treatment. And what we were able to show, we gave about 400 patients this chemotherapy-like regimen, 261 in Echo, 146 in the university. And we showed that minorities we could help. 68% of Echo patients were minorities, p-value 0.1. And the cure rate was identical for hepatitis C treatment, whether you were treated at the university or in a rural area. This was a game changer. When we published this in the New England Journal of Medicine, the paper came out in the middle of the night. When I got up in the morning, the paper had my email address at the bottom, right? As you know from all NEJM papers. In the morning when I got up, I had emails from all over the world saying, aha, we want to use this in our country to tackle diabetes. I want to use it for mental health disorders. I want to use it for geriatrics and so on and so forth. Now we have a lot of publications on Echo. We have 540 publications on Echo. I just told you about 2 so far. And I'm not going to share all 540 with you. But the evidence is that Echo can improve quality and safety. It can have rapid learning and best practice dissemination, reducing variation in care. It can improve access for rural and underserved patients. It could do workforce training and force multiplier. It can improve professional satisfaction and retention. And it can provide cost-effective care. The VA has shown they can reduce cost of travel enormously by doing echo. It can prevent cost of untreated disease like dialysis in diabetics and liver transplants and hepatitis C. But a university like Texas Tech, the global leaders like you, have to adopt the idea that if we want to produce equity in the world, we want to democratize the implementation of our best practice. This is not so, this is easier said than done. You know why? Because knowledge is money, knowledge is fame, knowledge is power. We like to monopolize it for our own benefit. But the idea of echo is that if you want to produce equity in the world, if you want to produce equity in the state of Texas, you want to democratize. Because, you know, we talk a lot about equity and we talk about sharing money and giving grants to rural areas, but you know, sharing money is a zero-sum game. Because if I have $100 and I give you 50, I'm only left with 50. But if I have knowledge and expertise and I democratize it and give it to you, and in an all teach, all learn platform, I learn from you, my knowledge increases too. Knowledge grows with sharing. What I like to say is the physics of knowledge is different from the physics of material resources. And that is fundamentally the power of ECHO to improve quality of care globally and to produce more equity. So now I talked about hepatitis C, but the next step was I said, look, it could be used for many things. So I described 6 criteria. I said, if it's common disease, it's complex treatment, new treatments are coming, there's a high societal impact, there's serious outcomes of untreated disease. And if you can improve outcomes with effective treatment, you could use it. Right now, we have ECHO all over the world for more than 70 healthcare conditions, okay? Like chronic pain, like critical care, like diabetes, care of patients with dialysis and oxygen therapy or palliative care or LGBT care or maternal and child health and on and on. We practically do ECHO for all the major healthcare problems in the world right now. In New Mexico, we have 19,000 unique learners who have attended 242,000 times. We have currently 34 healthcare networks, and we have now 30 networks in education. And I'm going to make a request to the Texas Tech team here, which is such a world-changing team. I'd like you to introduce ECHO to your public education department so they can use it to improve K through 12 education in rural Texas by mentoring school teachers to become better teachers in math and science, to train school principals in leadership, for early childhood detection, for risk for addictions, for mental health disorders in children, and so on and so forth. We have done many projects in education, and we find teachers love ECHO more than doctors love ECHO. So the goal of ECHO is force multiplication, improving capacity 10 times. If you can have a nurse practitioner produce the same level of care as a specialist, if you can have an internist produce the same level of care as a specialist, you're going to get 10 times capacity to deliver best practice. You will change healthcare in Texas if you applied ECHO universally for common disease areas. So the next question that came up to me was, okay, this works in New Mexico. Will it work anywhere else? So this is, we said we would train any university in the world, any not-for-profit. We would give them our software. We would even give them our Zoom platform to do ECHO. So this is University of Rochester publishing data in 2016 to improve geriatric care, 11 nursing homes, 22 controls, this is geriatric mental health, echo facilities were 75% less likely to be physically restrained for residents and less antipsychotic use. This is, they trained, this echo age is Harvard University, 11 nursing homes, 22 controls. Echo age is Harvard. University of Rochester did for geriatric mental health. They trained 500 clinicians, reduced emergency room visits and overall cost. The Veterans Administration Health System adopted echo and showed that the risk of death from cirrhosis of the liver was half, hazard ratio 0.54, if primary care doctors participated in echo versus the rest of the primary care doctors. P-value 0.003, again published in the leading liver disease journal in the world called Hepatology. Another paper from the VA on a huge number of patients, 6,000 patients versus 32,000 patients. 21% of people who were getting care from an echo practitioner got treatment of hepatitis C versus 2.5% of the others. This is US Department of Defense for opioid use disorder. 99 clinics versus 1,283 clinics. The practice was much better. Less opioid use, less co-prescribing with benzodiazepines, p-value 0.04 in the 99 echo clinics versus the control group. So I talked about 543 publications. What are they showing? 320 show that it produces joy of work, basically. 262 show that knowledge improves. 137 publications based on electronic records showing that they adopt best practice, that essentially their practice changes, quality improves. 78 showing that patient health outcomes improve, and 9 showing that the health of the community improves. This is an area of interest, I'm sure, for you, where we were able to improve capacity. This paper got the award for the best paper of the year, where we could share that for low-income and minority neighborhoods, we were able to improve capacity to treat in New Mexico 4 times above the national average for opioid use disorder. So we also use echo for training community health workers, medical assistants, and nurses. It's not just for doctors and nurse practitioners, because we like to say chronic disease management is a team sport, and we want these teams to all have best practices in patient education, best practices in patient support, so that the internal medicine doctor practicing in a rural area can have a team to help them. Another area of huge interest for us is prison health. So we have actually now trained more than 1,000 prisoners to become community health workers, who in turn have trained more than 10,000 prisoners. This is their graduation ceremony. We use the ECHO model to train these other prisoners. So each of these community health workers in the prison then goes ahead and has classes for prisoners to train them. This is a very impactful program that Texas should consider, I believe, to improve prisoner health. This is Albuquerque, where I live. Our hepatitis C project, all the learners. These are all the hubs in the United States. We have 408 academic hubs in the United States. All the major universities have adopted ECHO, like Stanford and UCSF or MD Anderson, Baylor, Texas Tech, etc. And we have Harvard and Johns Hopkins and Yale, and 408 of them. We also encourage you to think about the cancer space. There's a lot of disparity in southern Texas on things like creating experts in smoking cessation, in cervical cancer prevention. There are not enough palliative care experts in rural Texas. Survivorship care. So somebody comes to Texas, gets care for cancer, then they go back to the rural area. There's no doctor there to manage their survivorship care after cancer. We went to Africa in 2015. This is Namibia, to get 200,000 HIV patients on treatment. This is Windhoek, the expert team in Namibia. Namibia is at the very south of Africa, right next to South Africa. This is Vietnam multi-drug resistant TB echo. India multi-drug resistant TB echo. We now have 183 launched hubs in Africa, another 435 hubs in the pre-launch phase all over Africa. These are the 14 ministries of health that have signed collaborative agreements, just like Texas Tech has, and have launched echo projects. This is data from the US government, where they were training doctors on HIV care in Western Kenya as part of the PEPFAR project, which is the President's AIDS Relief Project, a global project. It was costing them $820 to train a clinician and make them experts on HIV. They used echo, and it now costs them $21, and it's more effective. And the reason it's more effective is because echo is the drip irrigation method of training. So they would fly these doctors to Nairobi from Western Kenya and give them 3 days of training and then send them back and hope that basically they would provide best practice care. It's not quite so simple. And so you can reduce cost 40 times for the US government, save some taxpayer money, and have more impact. Globally, we have 1,041 hubs now. These hubs are located in 67 countries. Our learners are in 194 countries. We have 193 members countries of the United Nations. One other country where there are learners is the state of Palestine, which is not yet a UN member. But here's an example getting back to hepatitis C. This is India. The main academic center was treating 1,500 patients of hepatitis C every year. That's a lot, 50 every day, right? But there were 600,000 patients in the state. They adopted echo in 25 district hospitals as learners. And they showed a 91.6% cure rate in 48,000 patients, and now have treated actually more than 100,000 patients there. Talking about force multiplication, globally now we have 4.7 million learners in these 194 countries. And you can see echo keeps growing, and Texas Tech data is in here too. So we are, thank you for sending us data, and thank you for being such an amazing partner. And, you know, I see you not as a hub partner, but I see you as a global leader in our mission to change the world and make it better. This is our team. Without them, nothing would have happened here, at least in New Mexico. So what makes echo work? You know, we want to, of course, use technology, force multiplication, demonopolizing knowledge, all teach, all learn. The goal is task shifting, making every human being work at the highest level of their human potential through many experts of Texas Tech helping them. Guided practice, mentor-mentee relationships with the doctors and nurses in rural Texas, building communities of practice, producing joy of work and resilience of these doctors. I like to say what makes echo work is love and respect and kindness and empathy and community, not just knowledge. what are we trying to do? Can somebody unmute and tell me which movie this is? One person has to unmute and tell me.
Godfather.
Yeah, this is Godfather 1. This is Francis Ford Coppola leaning over Marlon Brando, who's the protagonist. And he's asking, how do you make a great movie? And Marlon Brando says, get everyone to agree to make the same movie. Now, one of the biggest catastrophes in the United States is that rural doctors are making different movies than academic centers like Texas Tech. If you look at quality of healthcare in rural America, if you look at quality of healthcare that low-income patients are getting in rural America, if you look at quality of healthcare that the minorities, Black and Hispanics are getting in in America, in the US, it's lower. We are not making the same movies, guys. We want to use Echo to make the same movies. I want to end by saying the purpose of Echo is equity. We want more equity in the world. How do we do that? By building agency at the front line through capacity building. How do we do that? We want to democratize the implementation of best practices. Echo can do that, but others, whatever else you want to use. And we want to enable organizations. These could be federally qualified health centers in Texas to enable to achieve their mission with speed, scale, fidelity, and low cost. And by upskilling this workforce, you are going to produce better care for underserved people. And we want to produce gender equality. A lot of women in the world don't have the same access to healthcare, to knowledge, because they often have children. They can't travel. So by taking this knowledge to their doorstep, you can produce more gender equity. I will end with just last 3 slides. Just as I want to give you, in April of 23, I asked ChatGPT to write a poem on Echo. So I want you guys, I'm going to give you 1 minute to read this poem. Anyway, so what I wanted is, the reason I was showing you is just to show you, to every internist on this call and every resident, that after I asked ChatGPT to write this poem, it took it 4 seconds to write this poem, basically. In 4 seconds, it created this poem. So our world of medicine is about to change. And we have to ask ourselves this question: how will it impact? If somebody can look at all what Echo has done and write this poem in 4 seconds, you know this technology will change the world. Last couple of slides this is specifically for the residents in this room. And this is my favorite quote in the world. This is also the reason I started Echo. This is Albert Schweitzer, a physician who worked in Africa to serve underserved people. And he said, I don't know what your destiny will be, but one thing I do know, the only ones among you who will be really happy are those who have sought and found how to serve. I found this to be true in my life. And I want to carry this message to the residents in this room. And you can tell me later if there were any residents in the room. But the reason I'm carrying this message is, this is a really important message for any young doctor, that the only ones among you who will be really happy are those who serve and find how to serve. Many people go into medicine for many different reasons, but if they don't take service as their first mission, it is going to be very difficult to have a joyful life. So, and the last slide I want to show, again for the residents, is the never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Your leadership team at Texas Tech has joined our team to change the world, and I invite all of you to join us because we can make the world better. So thank you for your attention, and I've left 15 minutes as instructed for questions.
All right. Thank you, Dr. Arora. That was an amazing talk. For the audience, please don't forget to fill out the session evaluation survey to obtain your CME credits. And we will now open the floor for questions and discussion.
Dr. George, I think you have a question. Dr. George is our nephrologist.
Hi.
Thank you, Dr. Arora, for the great talk. I see you as a great visionary. But the question I had for you today is, how do you determine how will you determine a nurse practitioner or a PCP is competent to treat such kinds of diseases?
Yeah, I think that we start off with the assumption that full competence is not necessary. We are not a licensing body. We are not a certification body. And very much starts working Lekha in a very simple way. Just like you get a phone call from a rural provider asking about how to manage a patient with proteinuria, right? You don't try and determine if this person has competence or not. You help them, right?
Mm-hmm.
We start just like that. People join us. Let's say we are having, let's say that you start a clinic for prevention of end-stage kidney disease, okay? People will come to you on that clinic when they have cases, and they will present these cases and you'll help them manage. Over time, some will just come once or twice and manage their patients, but some will develop a special liking for you, Lekha. And they'll say, oh my God, I want Lekha as my mentor. I want to hang out with her once a week because I like her. I like her as a person. I like the way she respects me. And they will come and present cases to you. Over time, they'll become experts. You're not going to certify them.
Mm-hmm.
But what we have found is that doctors self-regulate what they do. Because you at Texas Tech are never going to tell them now you are competent to do this. But they will first crawl, then they will walk, and then they may run. Or they may decide, I don't want to become a nephrology expert like Lekha. I want to join somebody else's clinic on diabetes or somebody else's hepatitis C clinic. This is not a certification program, but I have to tell you that we have 4.7 million learners in the world, right? In 194 countries. We have never had a lawsuit in ECHO in 20 years. 20 years, 4.7 million learners. There has never been a lawsuit against ECHO. Now, fingers crossed and touch wood, but I'm just saying, it works, it works just Lekha, just like you. When you get a call from somebody to help them, you help them. You don't ask the question, how do I know whether they'll do a good job? I hope that was helpful.
Thank you.
That's actually related to my question, Dr. Arora. Do you have any medical legal cases from Project ECHO because they're not certified? But you answered the question and there's none. And I'm here with my medical student raving about how great Project ECHO is. And I think there's a lot of applicability of Project ECHO. I think though, my question though, Dr. Arora is, and you probably have the same issues here with the University of New Mexico, is how to make our providers adopt Project ECHO because they're already busy. I understand they have their academic life. their clinic life. But how do you get buy-in for them to adopt Project Echo? Because sometimes they say, well, it does not really pay. And how are the financial rewards for the clinicians, to give their time to Project Echo?
It's a really
Dr. Arora, before you
really
answer that question, hello.
Hello, Rama, go ahead.
So I'll ask a question that precludes what was just asked. So, it's truly visionary work you're doing. It started off as chronic hepatitis C in New Mexico, and now you're doing worldwide work. So how have you sustained the funding for this? And just can you give us a brief background, because you're doing tremendous work there?
Thank you. Yeah, I think, so first important thing is, thank you for the medical student for the compliment that Echo is a good model, because it's you who are going to change the world, right? I think the important thing here is we have a huge problem in the United States, okay, here, where so much of the work we do is driven around maximizing revenue for doctors, for hospitals, for pharmaceutical companies, and in a fee-for-service model, there is very little incentive to democratize expertise for the health of your population. So let me just start by saying, it doesn't fit into fee-for-service model. Yes, the rural doctor will get paid for the work they do, but the specialist gets no money. So then the question is, how is Echo funded? Okay. A lot of echoes in the world are done by specialists who have the same problem as I was having. That I became a global expert in hepatitis C. I was as good as anybody else in the world, but the only people I could help was the people I saw myself. That was a very limiting thought. I was a slave of my calendar. I could only help a few people. And I knew I would retire and take all this knowledge and expertise out of circulation and then into the grave. I wanted to have a bigger impact on the world. And so I did it for my mission. I was blessed with one key thought that I always had for many years, that the only way I could be happy in my life was if I devoted time to serve others, okay, who were less fortunate. So I did it for that purpose. That is a law. What I just said, that is a universal law, okay, that the only way you can be happy in your life is if you follow that law. All other roads are dead ends, okay? So that's one reason why people start Echo. But then I think, Rama, you're asking a more important question. Let's say you want to do this at scale, you need money. How do we get funding? We went to our legislature and told them, look, fee-for-service doesn't cover this. But if we upskill our workforce, rural patients will get better care. And the legislators are all from rural areas. And they got convinced, and we get $6 million a year from them for all our Echo projects. So just to give you one example, on Medicaid, we convinced them, we said, look, you guys have certain time and distance parameters. That is, a Medicaid patient in a rural area should be getting specialty access within a certain time, within a certain distance. And you are not meeting it ever, by even a long shot. You're not even close. We can help you meet that. So they support our work too, through the different health plans. Then, because we have 540 publications, the US government uses Echo. They have given out $2.5 billion. That is $2,500 million of grants to replicate Echo in the United States. And Texas Tech happens to be a beneficiary of one of those grants, isn't it? And congratulations on that. So what I'm saying to you is, if you want to do it, you reach out to TexLa Echo, and they are experts at grant writing. They'll help you create an echo for yourself, and you reach out to them. But this is the Achilles heel of echo. We still haven't figured out a way how to integrate echo into the US healthcare system to serve all. We are trying, constantly trying, haven't been fully successful, but I'm an optimist. Remember, we want to change the world, and it's inevitable. So I hope that answered your question, Rama.
Yes, yes, Dr. Arora, I did. Thanks.
Okay, we still have 5 minutes in case somebody has any other questions.
Any other questions from the internal medicine grand rounds room? You could just unmute and ask the question if you do have. By the way, Dr. Arora, that's an excellent point, with the ChatGPT, kudos to ChatGPT for that. And I actually telling my medical student here that when I attended the Project Echo workshop, one of the supporters there during the dinner even would like to nominate you for a Nobel Prize, either for peace or for medicine. So, I don't know if that will, it seems to be getting near. So, very supportive of that as well.
Thank you for your kind words, but I will donate the money to Echo if I get it. I think here's, it's really a pleasure to collaborate. Much more importantly, your collaboration with us is so critical. And there's this wonderful comment by thank you, Jennifer, for your kind words. Derek Ramsey says, seems to me ChatGPT is making the same movie. Yes, and I think what happens is ChatGPT will enhance Echo, and we have actually already integrated the platform to our new iEcho, and it's being pilot tested in India right now, where ChatGPT will act as a partner to the expert nephrologist to provide the right information, not just for the doctor, but for also the specialist. The second important thing is it's going to basically track each of Lekha's mentees, their individual learning journey throughout their learning process, issue digital certificates as they progress, and give recommendations to those mentees of Lekha in rural Texas of how to scale up their learning and expertise further. So yes, we've already done the integration. I have a team of 40 software engineers in Delhi working on that. And I don't know whether you guys at Texas Tech, TexLa Echo have actually adopted the new Echo platform. But I would encourage you to reach out to UNM to adopt the new Echo platform, because it'll track all the data for you automatically. It is an amazing new tool. We spent $10 million developing it, and we are giving it away free to everybody in the world. So out of our 1,041 hubs, 350 have already adopted it.
Dr. Arora, I certainly, whether I have mentees, I'm going to be your mentee for sure. And I do love to participate in your project in India too. So I'm looking forward to collaborating with you, certainly, especially in treating patients with ESRD.
Thank you. Thank you, Lekha. Okay.
Well, this is excellent, presentation, Dr. Arora. Before we go, I'll give you to Laura Rowell here.
Yeah, so I just wanted to bring up this screen again to complete your session evaluation if you want the CME credits. Oops, sorry. And then we also, of course, wanted to say thank you, Dr. Arora. Thank you so much for the fantastic presentation and the discussion we've just had. Thank you to everyone that joined us as well. We'd like to present you with our challenge coin, the TexLa TRC challenge coin, for the webinar today, and also for your pioneering work in democratizing specialized medical knowledge and improving patient outcomes around the world, not just patients, students and and all the other specialties it's now been applied to, as you mentioned. So thank you so much. Once again, it was an absolute pleasure to have you with us. Sorry, my screen is not moving forward here. Oh, there we go. And then just as a last spotlight on our upcoming Telehealth at the Crossroads Conference. If y'all want to join, please feel free to check out our website, see more information on that. But this year's conference will take place in Lubbock, Texas here on Thursday, July 27th. And an email containing a link to learn more and register for the conference will be sent out to all participants of today's event, along with the link to complete the session evaluation for today's session. So thanks again for joining us. Thank you again to Dr. Arora, and hope you all have a great rest of your day.